Welcome to session 64 of Virtual Shadowing's pre-health program. Tonight, we're joined by Dr. Gil Salazar, as he'll be talking us through the 3 I's of entrepreneurship in medicine: innovation, inventions, and intellectual property. Could you please go to the next slide? So for our upcoming sessions, originally for next week, we had planned to have a robotic surgery, but unfortunately, due to some sensitive material in their presentation, we are unable to have them part of our program just because we've never gone through such, we've never had to enter into any contractual things with providers. And for this to be brought up now, it just seems like a little bit of a hassle. So instead, we will be having Dr. Fowler and Dr. Benjamin Nguyen, who are both on the Board of Admissions at UT Southwestern, do a session over medical school interviews. On 8/24, we'll have clinical psychology and research. On 8/31, we'll have emergency orthopedics and sports medicine. Please be sure to join us on Zoom or YouTube Live at 7 p.m. or feel free to watch the recording on YouTube the week following each session. Next slide, please. Here we have our virtual shadowing working group. On the left, we have our undergraduate students, many of which have graduated and have left us for medical school, which is all good news. And on the right, we have our faculty directors, Dr. Fowler, Dr. Morchetti, Dr. Salazar, our speaker tonight, and Dr. Reno. Next slide, please. If you haven't been here before, then please feel free to put all of your questions into the chat, and we'll be sifting through them and making sure that all of your questions get answered during 2 Q&A sessions, one in the middle of our presentation and one at the very end. Now, Dr. Fowler would like to say a few words before we get on with our presentation.
It's so good to have you all here again. This is, gosh, over 60 lectures that we've done. This is such a wonderful thing for us and the working group and all the students that participate, and we're so happy to be here. We want you to know that if you keep coming back, we're going to be here. This is an important time because this will be the first real season in which virtual shadowing plays a role into admission committees of medical schools and other pre-healthcare. So we will keep you updated as far as what we understand and what we know as far as the effect of virtual shadowing hours is for the applications process. And so we will keep you posted as we go forward. In any case, we're so glad you're here. This is an absolute pleasure for us, the members of the working group. Delighted to have you. And tonight we have our extra special, my favorite person in the world, Gil Salazar, who's going to talk to us about something that you're going to find very, very interesting. So Aditya, would you introduce our guest for this evening?
This evening, we have Dr. Gil Salazar, and he will be talking about the 3 I's of entrepreneurship. Take it away, Dr. Salazar.
Well, good evening, everybody. It's so nice to be back in virtual shadowing. Life has taken me in different directions. At the end of the day, something that Ray Fowler himself taught me is that it all comes down to the people that you work with, and those folks are your family, and those are your forever family. So nothing ever changes. It's really, really nice to be back. We were discussing something interesting and engaging, maybe a little outside the box to talk to you about. And I think those of you who know me, and for those who don't know me, I'm into a lot of things, okay? And one of the things that you may not know about me is that I'm an absolute geek when it comes to medicine. I'm a geek when it comes to gadgets. I'm a geek when it comes to kind of the next big thing. And I'm actually a pretty impatient guy. So I figured that today I would bring you a little bit about another aspect of my career, which has been very, very fulfilling. But before I do that, I'd love to tell you very briefly about me. I'm an associate professor of emergency medicine at UT Southwestern Medical Center. Is my 13th year as faculty within the program. I am just like Dr. Fowler. I am board certified in both emergency medicine and emergency medical services. So everything that has to do with out of hospital medicine, ambulance services, law enforcement, we have some knowledge. I am also very, very glad to have a good friend of mine here with us tonight, and that is Dr. Coco Trigo. Dr. Trigo did his residency with us in emergency medicine. This will be kind of 5 years ago, or 4 or 5 years ago. He would have completed that, and went on to do a fellowship in simulation medicine at UT Southwestern. Dr. Trigo is now at LSU in New Orleans doing another fellowship. So if you thought Dr. Fowler and I were crazy with fellowships, Dr. Trigo is even crazier, doing his fellowship in pain management, pain medicine. So it's really a pleasure to have him here. And one of the reasons that Dr. Trigo is here with us tonight is because he is another big geek. And I've had the honor and pleasure of mentoring him throughout his journey in innovation. So we both wanted to share some of our experiences, some of our journey in innovation, and tell you why it is that this is such a fun, exciting pathway that's a little bit different than what we do on a day-to-day basis.
Gil, I will say that the word geek in my world is a high compliment.
Yes, sir. I consider that an absolute honor to be called a geek.
A geek.
And so you have to be a bit of a geek to go into medicine. And I think you have to be a geek to be really good at it. As we get started, I wanted to thank everybody for being here tonight. Just a brief kind of announcement in general. COVID-19 is once again hitting our doors very, very hard. I don't mean to bring the spirit down, but it's the truth. As I walked into work this morning, I worked the critical care area. 5 of my 6 critical beds were COVID positive patients, and I did not have a place to see new critical patients. We were overflowing into other areas. Within an hour, really within 30 minutes of my arrival to the hospital, I had intubated my first patient who was COVID positive, struggling to breathe, fighting for his or her life. And so I urge you to let's do the right thing. I don't want to see folks die anymore. Take care of yourselves, mask up, get your vaccines. And if you ever have any questions, please feel free to reach out. We are here for you. We're so delighted that we're choosing this platform to get you some education, and we're here for you. So
Gil, worldwide, 4.4 billion people have taken the vaccine. Do you think we've got enough information now about this vaccine to know that it's safe?
Yes, sir. We absolutely do. Everybody was afraid of kind of being the guinea pig of things, and we got to remember that thousands of individuals went through the initial trials, and every phase that is necessary to bring a vaccine to life, every step was followed. And we got to remember that although the steps seem pretty fast to us, every single barrier was overcome to get that vaccine our way. And trust me when I tell you, Dr. Fowler, Dr. Trigo, we do this for a living. We make it a living of getting to know the science for the benefit of our patients and to make life better for everybody else. And the 3 of us put the vaccine to the test. And the 3 of us made the decision that it's the right thing to do. So you got 3 physicians who really care about you, telling you that this is safe. And all of us are here standing tonight, really hoping that our communities and your families will do the right thing. So thank you for indulging me.
Thanks, Gil. Rock and roll now.
All right. Well, guys, let's start with a bit of a clinical case, and you're going to be excited to know that as we go through this presentation today, I'm going to mix in some cases. I'll give you a case, then I'll bring you a little bit of kind of some pearls of knowledge, then I'll give you a solution to some of these cases. All right. To make it worth your while being engaged tonight, I'm going to be doing a giveaway tonight. I like giveaways. As medical director for Virtual Clinical Observation Program, which is a sister program of virtual shadowing, I really love the opportunity to engage with you and give stuff away. So to a lucky winner tonight, I'm going to be giving away a t-shirt that bears our logo. And this thing is really, really nice. And Cheyenne, if you could show yours as well. So Cheyenne got his t-shirt, and it's going to be very simple. At the end of the presentation, you can see that my Instagram account is there. I'll actually put it up again. you got to give me a follow and you got to DM me that you checked our website, and we're going to put it in the chats, vcop.ws, virtual clinical observation program.ws. So got to be following me and DM me that you checked out the website, and I'm going to enter you in a giveaway to win one of my t-shirts. So here we go, folks. These are real life cases. I tweaked some of the details to protect the patient's privacy and the family's privacy, but these are all real cases. A 42-year-old patient is admitted to the hospital with an infection on her forearm. This patient struggled for many years with heroin addiction. And unfortunately, on one of these admissions, she came in for an infection. She's receiving IV antibiotics through intravenous lines started on her forearm. The day after she was admitted, she was found in her hospital bathroom, unresponsive, with a syringe with an unknown substance that initially it was unknown, turned out to be heroin, was found hanging in her existing IV started that was started by the hospital. So let's, I want to hear in the chat for everything that we do here for these cases. I want to see if you can come up with some solutions. What would you guys do if you were kind of in charge of trying to find solutions for this? So put it in the chat as we talk. And I'm going to start talking about kind of why innovation is such an important deal. So why do people like me, why do people like Dr. Trigo like innovation? Well, it's very, very simple. It all comes down to the fact that we are constantly seeing problems. Problems are all around us. And you may think that we know everything sometimes, and you could not be more wrong. We actually know very, very little when it comes down, if you really want to be honest. And so we're constantly finding ways of improving medicine, of improving our patients' lives. And so we are constantly surrounded by all of these conundrums, some very, very tough situations, just like this patient. And one of the most important things to remember is that we as clinicians are critical thinkers. That's what we get paid to do. That's what we go to school for so long. That's why getting to medical school, PA school, nursing school is so tough. We are critical thinkers. But you got to remember this, that at the end of the day, no matter how big the problem is, there is a solution. And there are people out there who really want to think about ways of solving it. So if you ever want to really learn why it is that we do what we do, it is because we're trying to solve simple problems. So this case that I showed you actually put an idea in my head. It's like, how do we prevent this from happening? I said, so the solution to problem number one was actually my very first invention. So I bring to you US patent 9907907B1. Okay, granted in 2018. My friend John Purcell, a former colleague of mine, we started thinking about how can we prevent this from happening ever again. So we put in a lot of time and effort, and we're going to go through all the steps that we took. I said, at the end of the day, after 5 to 6 years of really working on this is a long process. We come up with my very first patent, and the solution was a kind of a very fancy concept. We call it an intravascular, could be an IV in the vein, could be an artery, a catheter tampered deterrent lock. Essentially what this does, if you refer to the figures there on the right, that little line here, that's the existing line that goes in the patient's vein right here. That's an existing line. And what we're actually going to do is we're going to put a little bit of a lock on that existing IV. And you can only access that lock using a specified syringe that goes to that lock. The concept is therefore very, very simple. Unless you have a hospital issued syringe adapter that you can unlock this tamper deterrent lock with, you cannot access your IV line. So we could have very easily prevented this patient from accessing her own IV line and injecting things that didn't belong there if we had taken some additional measures to do it. And you might think to yourself, why had nobody ever thought about this before? I said, this really illustrates the point that problems are all around us. And I'm here to tell you, when you get that that patent, that validation of all the work that you've done is really an honor. So this patent, you can easily find it on Google Patents. It's the Patent Office for the United States has this readily available. And so we found a very simple solution to a very big problem. And our hope is that we're going to save a lot of patients' lives by introducing this very simple concept that took a lot of work, a lot of innovation, a lot of engineering, a lot of sweat and tears, quite literally, to bring to life. All right, so let's talk about intellectual property. You remember the 3 I's: innovation, intellectual property. Really, I want to kind of hone in on the definition of intellectual property right here. And I want you to look that this is a work, a piece of work, something that you have designed with using your own brain, your own creativity. It can be really anything. We're going to talk about some things that are considered intellectual property. It can be a manuscript. It can be a design. It can be a concept to which one has rights. And these are legal rights, and for which one may apply for a patent, a copyright, a trademark. Essentially what this means, that intellectual property is something, it's an idea, a concept that you've worked on before, and now you want to protect it in the interest of innovation, in the interest of bringing it forward. And really, if you want to simplify life for yourself, it really means that you don't want anybody else taking your idea. So you want to protect it. We're going to talk about different ways of protecting intellectual property. It's just really amazing to me that, we have all these great ideas and now we have a methodology to protect your idea. So notice here that we talked about there are different ways of doing it: patent, copyright, trademark. We're going to talk about some of these. All right, let's go to number 2 over here. Now, this piece of work belongs to one of my favorite colleagues, Dr. Fowler, Dr. Trigo are 2 of my favorites. A third colleague of mine, Dr. Eric Kolstad, is an emergency medicine physician. He works at UT Southwestern. He works in the trenches with us, and he is one of the most humble, soft-spoken individuals you're ever going to meet. What he may not tell you unless you start talking about him is that he is incredibly smart. And he saw the following problem. He noticed a 27-year-old athlete who collapsed on a field. The patient received cardiopulmonary resuscitation by bystanders, and EMS went ahead and shocked the patient with a defibrillator, and the patient actually gained pulses. We call that return of spontaneous circulation. Now, one of the concepts in cardiac arrest, especially with some special types of rhythms, is that we learned that cooling the patient, bringing their body temperature down after cardiac arrest, helps preserve the patient's neurological status. Patients have a lot more success walking out of the hospital, leading a productive life, being able to function on their own when we institute certain things like therapeutic hypothermia. Now, one of the problems that Dr. Kolstad saw is that not every receiving facility, every hospital has the capability to really cool the patients, number one, and to figure out a good way to monitor the temperature for these patients. Remember that a skin probe, for example, a finger probe, or even a thermometer can have fluctuations. The equipment may not be working. And Eric Kolstad actually was thinking of a way to ensure that the patient's cooling, their body temperature, could be monitored very closely. And so he saw a problem. He is a critical thinker. He saw that there was a possible solution, and he began to think of an idea to make lives easier for patients, bring a return of spontaneous circulation to life, and allow that patient to walk home. So we're going to talk about the solution here shortly. I just want to kind of put in your frame of mind what intellectual property is all about. So let's talk about what are the different types of intellectual property. Well, we mentioned mine. Mine, for example, is a very simple device. But intellectual property, once again, just to recap, intellectual property is a design, a product that comes out of your own creativity that you're going to have rights to and that you want to protect so that nobody else takes it. Okay, so what are some things that you can consider intellectual property? Well, devices, that's the easy one. Dr. Trigo, Dr. Kolstad, and I really love medical devices, but things like software, that's a really hot one. Apps, even some of you in engineering schools have helped us design apps to make life easier for patients and for clinicians around the world. They can be written works. They can be publications. You remember that people work hard. Clinicians, healthcare professionals, and scientists work really, really hard, and you want to protect that. So written works are intellectual property. What about processes and methods? For example, at UT Southwestern and universities around the world, there are many things that come up in our laboratories, new processes, new ideas, new methods of extracting DNA, the beautiful process of designing and developing an mRNA vaccine. These are types of intellectual property. And also don't forget that pharmaceuticals, which is considered really an innovative biological material. That's a really hot item. Pharma, big pharma, as some people call it. Well, all of those formulas, all of those medications, all of these processes that go into creating a medication for patients and remedies, that is intellectual property. So Coco, tell us, if you don't mind, tell us a little bit about software, kind of your experience with software as intellectual property. Tell us about the app you developed.
Yeah, so software is a whole different ball game from devices. I am not that good at I don't know anything about coding. I like to get people to join my team that will help me with my deficiency. So software is very different. So software, for example, for apps, with apps to be something completely unique and creative, you have to code for everything. But nowadays, if you want to get something out there in the market faster, you can use pre-coded or kind of already set up apps where you can just grab functions from different websites or different coders, and you can just have your app up in the App Store in less than a month, which is what I did. I am very, very impatient. I think even more than Dr. Salazar. I'm takes more than 5 seconds. I'm already out. I'm done. I needed to be right there. So I found a very good group of two actually bioengineering students that were looking for projects, and they reached out to me and they developed an app that way. And the thing with apps are very hard to get a patent on. And that was one of the things that we were gonna get stuck. Yeah, the idea of the app, it is unique. It is, no one had done it before, but we had not done our own coding. So now we're actually in that process. We were using other templates and other platforms to be able to get our product out there faster, kind of to test it, because you first want to test how much are people going to use this. You're going to put so much time on it. You want to make sure this idea is worth pursuing. So that's kind of how we fast track it with the app. And then you see, okay, this is going to work. People are going to like this. Let's put the time on it. So now you want to make all the coding unique, which is where we are at this time. And it's good when you do this with universities, because when you do it through a university, which is what myself and Dr. Salazar have done, they actually guide you through this process, how to protect each kind of these intellectual properties. Because it's not the same as protecting a device, protecting a written work or software. Each one of them have their intricacies. So that's kind of how my process is with software. Software is a hot topic out there. It is medtech industry, I think it's one of the fastest growing markets right now, especially with EMR nowadays. Everyone wants to have their own software. Everyone's trying to improve technology. So if this is something you're interested in, there's a lot of space here.
Thank you, Coco. And one of the things that I wish to highlight is that people like myself and Coco Trigo are practicing physicians. We devote really the majority of our time taking care of patients, but we are also very interested in this much different and even really exciting aspect of medicine, which is intellectual property. So let's talk about the solution that Dr. Kolstad came up with. And so entered case number 2 solution, and that is esophageal cooling and monitoring. So one of the main concepts when it comes to cooling patients is you got to have a really good idea. There is a very, very tight frame, very tight temperature range that is really effective toward maintaining good neuron function after cardiac arrest. So really a simple thermometer that goes in the patient's mouth or the forehead is not going to cut it. Dr. Kolstad and his team spent several years, and there are famous pictures that that he's shared with us of him and his partners using his bathtub to do experiments, using coolers, etc. And they came up with the concept of actually doing body core temperature monitoring and cooling using a big catheter that goes into the patient's esophagus. Okay. And even though some work had been done before, nobody had really dived into that market. Nobody had really developed the technology, because it's not just about inserting a catheter in the esophagus and letting it be. Think about the complexities that go into really creating a thermometer that goes inside a catheter, how you're going to monitor that, what are the sensors going to look like, what's going to be surrounding the sensor, stomach acid, products of digestion, etc. What are the monitors that are going to be watching over the temperature? How are they going to interact with the catheter? So Dr. Kolstad really founded a company. That is one of the ways that we're going to discuss shortly on how this is done. Together with his team, they created the concept, they tested it, they got funding, and we're going to discuss some of the methods to fund some of these ideas in a couple of slides. And at the very end, here is what his product looks like. This is part of Attune Medical. That is Dr. Kolstad's company, and this is their baby. Every once in a while, you get really, really lucky. And Dr. Kolstad actually found a use for this catheter that nobody had really thought about before. So get a load of this. You think you got everything figured out, and all of a sudden you get this bright light, this bulb goes off in your head. And what Dr. Kolstad thought about was the fact that during some procedures that cardiologists do on the heart, they're called ablations. When there are portions of your heart that are beating abnormally, creating abnormal electrical signals, cardiologists can actually kind of go in there and kind of ablate, kind of burn off, take away those little portions of the heart to take away those electrical signals. Now, one of the problems with this ablation, as we call it, is that it can create pretty high temperatures in and around the heart, in the esophagus. So one very smart cardiologist and Dr. Kolstad got together, and they wondered if this cooling probe could be used to cool patients' esophagus during these ablations. Guys, and that has become actually one of the main sellers for Dr. Kolstad's product. So initially, this was touted as kind of really for cardiac arrest and cooling for very hot patients, but now they found a use for a far more common procedure. So it's just really exciting to people like me and Dr. Trigo, how you have an idea in your head, and then all of a sudden it just develops into something different, and the dream of a lifetime of creating something meaningful and useful for the House of Medicine is truly, truly exciting. Let's discuss protection of your intellectual property. Dr. Trigo mentioned that, for example, the app he's developing, a patent is not a great way to protect it. And remember, just to summarize and to try to remember why we protect things, we don't want others taking our ideas and making it their own, profiting off of them. And so you really want to protect these, and we go to great lengths to protect our intellectual property. So what are the reasons for doing that? Number one, commercialization. If I have a great idea, Dr. Trigo has a great idea, Dr. Kolstad has a great idea, and we think that this product can actually sell units in the market, well, we want to be sure that we control the market for that. So we're going to protect that. So commercialization is number one. Number two is academic reputation. Dr. Fowler and I and Dr. Trigo work for universities, and part of our jobs is the creation of materials, creating knowledge, empowering science. And a lot of the things that we learn, a lot of these things that bring notoriety, they bring reputation to your university. And your university, your institution is going to be very interested in helping you protect those works so that no other university can go benefit off of those for reputation. And last but not least, I think the most important aspect of protecting things is you pride yourself as a clinician, as an inventor, in creating something that folks are going to use, something that is well designed, well engineered, and that you develop really a lifetime to. You don't want somebody else kind of taking your idea and making it cheaper, developing it, cutting corners. You don't want that. So I can tell you that of all the three things you mentioned here, commercialization, reputation, and quality assurance, to me, the fact that my little catheter is going to be made with quality materials and there's a patent behind it, that is my main reason for protecting intellectual property. Commercialization, of course, nobody goes into innovation and intellectual property without kind of thinking that they're going to get some type of gain from it, and that's perfectly normal. But for me, quality assurance is a big one. What are the types of protection? Well, copyrights. You all have seen the word copyright, and that really revolves mostly around written works, your creativity, books, chapters, articles. The word really in and of itself can be copyrighted. So nobody else has the right to copy your material without asking your permission. And there are legal ramifications to borrowing material, making it your own without giving proper credit to the original creator that owns the copyright. Number two, trademarks. Trademarks are really nice for goods, services, logos. At some, you saw my logo for virtual clinical observation program that is in the process of being trademarked, but we have created a service, and attached to that service we have a logo, and we don't want anybody associating their own product, their own idea with ours, so we're going to provide a trademark. I've also managed to get my first trademark for another product that I have on the market, and that is actually an educational product. Emergency preparedness and survival training is a concept, a series of courses that I designed. There's a logo around it, and we managed to get our first trademark. And so we're going to be using that trademark to teach things like hemorrhage control, our own brand of cardiac arrest, airway management, etc., active shooter drills. So a lot of these things can be protected by a trademark, and that is a process that is very, very extensive, can be very expensive. But once you get that trademark and you're able to add that little R that you see next to your product, that little tiny little R with a circle around it, man, that feels really, really good. And then the one that we deal with the most, that in my opinion carries some of the biggest weight, are patents. And patents is a legal document. It is provided by the U.S. Patent Office. It requires an application, a fee, and basically you are providing the U.S. Patent Office with enough evidence that your material is new, it's innovative. You tell them everything there is to know about the product, including the engineering, description, all of the measurements, what materials you're going to be using. And the U.S. Patent Office goes to great lengths to take a look at your intellectual property and see if it's original enough. Okay. They conduct something called prior art search. So they have to take a look, is there anything else that looks like the concept that Dr. Salazar, Dr. Purcell put out there, or that Dr. Trigo and his team put out? And if they see that there are similar products, they let you know, and you have to go back to the drawing board and make some changes to make it truly original. And what is nice about protecting your intellectual property with patents is that the legal ramifications for really using that material, those processes, those concepts that are patented, that is infringement of the law, and that carries some stiff penalties. And I'm going to be very honest, infringement happens even in academic centers. And so folks, if you're ever thinking about an idea, something that you want to protect, be very, very careful when you're designing it. Do your research. Hire somebody to look for prior art, other patents that may be similar to yours, because you don't want to infringe. You will be taken to court, you will get sued, and the outcome is not always friendly for you. Okay. Well, Aditya, let's stop here for a second and take any questions, and then I'm going to pick on my friend Coco for some other material.
Yeah, of course. We have a few questions for you. Dr. Trigo, feel free to jump in and answer them if you would like. First off, how many of these inventions are already widely used in hospitals, whether it be the one that you've created or the esophageal cooling mechanism?
Phenomenal question. The answer to that is that all of these products that you've seen here, and some of the ones that you're about to see, because we're not even halfway done, guys. These are protected, and these are original works. So at some point there might have been products that look similar, but one of the nice things about patents is that our products are unique enough and they're patentable enough that there is nothing like it on the market. And so that reassures your consumers, your customers, and your patients that nobody else has had that specific concept in mind. It hasn't been used for that specific purpose, and you have the legal protection to use it without anybody else infringing upon your idea. Now, how well or how often or how aggressively your product gets used, that depends on the marketing, and that's going to be the last piece of the pie. The last piece of the conversation tonight is going to be the commercialization aspect. So it really depends on where you are in the path. People like Eric Kolstad, they've been at it a lot longer, and obviously their product is far more developed than, say, mine or even Coco's. And to that degree, he has been able to commercialize it even more. So it's more widely used.
Awesome. Did you or anyone on your team have an engineering background in order to come up with this invention?
I'll start, and then I want to hear Coco. Ladies and gentlemen, I had 0.00000% kind of knowledge, expertise in engineering. My father is a civil engineer, but I'm not even going to count that as engineering experience at all. The thing that I did that I thought was one of the smartest things is surround myself with individuals who had the knowledge to bring this idea and engineer it with me, people that I like, people that I trust, and people who are remarkably intelligent. But I myself had no engineering background. I learned a lot as I went. So Coco, what's your experience with engineering?
I work as an engineer for like 20 years. I'm lying. I have zero as well. Zero at all. I don't know anything about engineering. I know how my final product has to look, how it's going to work. I have it imagined exactly how I want it. And I just do the same thing as Dr. Soler. So I like to surround myself with a good team that knows exactly how to get me there. And the key to this is breaking it down, explaining to your team how you want things done, and let them do their magic. And surround yourself with people you trust and people who are good, and things are going to happen. That's kind of zero, but I had zero engineering. But Dr. Kolstad actually did. Dr. Kolstad, I think he did his bachelor's in bioengineering, actually, and he knew a little bit more about that. And he used a lot of his knowledge for his device.
So that should make you kind of remember that you don't have to be an engineer to create intellectual property in the medical realm. We had an idea. We wanted to create a solution for a problem, and we went with it. So, all right. Thanks, Aditya. What do we got next?
One more or two more. How many people typically work on a team to develop the product?
Initially, your team is very, very tight. Remember that before you get any type of protection, we're going to discuss the pathway for protection for things. You don't want a lot of people knowing about your idea. The first time I ever told anyone about my idea that it is now patented was actually with my friend John Purcell. I liked him. He's a little bit younger than I am, just a very smart dude, very innovative. We went out for dinner one night, and I took him out to dinner because I really wanted his opinion. I really wanted him to be part of my team. And I told him, John, I am one of the reasons I brought you here tonight is I have an idea, and I want you to be very honest with me and see if you'd be interested in giving me your opinion. And if you're interested in participating in the project, then I'm willing to kind of bring you in and tell you about it. So initially, your team is going to be very, very small. As your project matures, as you come up to the next stage, you start kind of making your team a little bit broader. Now, once you reach a level in which you have some legal protection for your product, your team can grow exponentially, but keep it very, very tight, guys, very tight.
So Gil, this is Ray. So how do you, in the setting where you really need to do research on a subject, where it might be an R01 multi-year project before you could ever see any income off of it, how do you have the patience to do that?
I am sure that my experience is exactly the same as Coco's, and certainly Eric Kolstad's. You feel like you have the brightest idea of all time, but you might be the only person in the world that shares your enthusiasm. And many doors get shut in your face. Many people tell you that, nah, not interested right now. Many people who don't want to invest in helping you bring your idea to life. And you realize very quickly that that is part of the business. Part of innovation means that you have a great idea, but you're not going to give up, and you're going to keep knocking on doors, and you're going to keep believing in yourself. But it's very, very hard. And so remember when I talked about sweat and tears, the tears are no joke, no joke.
That's great. Thanks, Gil.
You're welcome.
Aditya?
All right. One last question. So once you have the idea of a product rolling, what does your typical schedule look like alongside you working as a normal physician as well?
Yes, sir. We there's quite a bit of variability in the amount of energy and effort that you put into your device. Obviously, you have a lot of energy at the beginning, but your energy and the amount of time you spend kind of goes in peaks and valleys. Sometimes you lose a little bit of steam, or your clinical practice gets stuffed and go and get stuff, and you might work on it less. And then all of a sudden you get a kind of an idea, a little bit of a support, a nice word from somebody, a development in your engineering process that brings you hope, and you work on it more. I try my very best to do, at the very least on a weekly basis, approximately 5 to 10 hours of innovation. Depending on the stage I'm in, I will spend a little bit of time every week on the product, on developing ideas. And trust me when I tell you that it's, I don't just think about medical devices. There are other things in the works. And so it's fun. Coco, how much time do you spend on your innovation compared to your clinical practice?
Yeah, it's very similar to, I think you did a perfect description. It goes up and down. When things are moving fast, I might spend up to like 30 hours in a week, but then there's weeks where I spend maybe an hour, 30 minutes. It depends where I'm at in the process. At the least, I think on average, I spend about 5 hours a week. And mostly I kind of like jam it all in one afternoon. And it's all kind of like email catching, some R&D, what's new, who am I need to talk to, commercialization stuff. And that's kind of like my average afternoon, like at least once a week is what I do.
Very cool. So let's move on to case number 3. Thank you for your very insightful questions. Speaking of Dr. Trigo, I'm sure that he has seen this type of case before, just like I have. And I'm sure that a case like this was part of the inspiration for his product, which we're going to show you here shortly. But let's begin with the case. This is a case of a 50-year-old gentleman who presents to the emergency department with a large leg wound. It is in a severe state. It smells bad. The patient is septic. That means that there are systemic manifestations to his infection. He develops a blood pressure that is low, which we call hypotension, and tachycardic, which is elevated heart rate. That means that he's very, very sick. The physician's taking care of the patient, insert an ultrasound guided. We call it a central line. It's really a fat venous catheter with several ports. It's got 3 of them to deliver several medications at the same time and being able to give antibiotics and fluids. And we have to insert that in one of the big veins in our body, most often your jugular vein, sometimes in your femoral vein, in your groin, sometimes right under your clavicle. So these are really, really big lines, and we do them under ultrasound guidance to make sure that we're in the right place. Now, we usually do these with an assistant. It could be a nurse, it could be a student, it could be another physician. Unfortunately, in this on this day, this physician, the assistant, became nauseated during the procedure and had to step out. Now, the physician is sterile. He's got a gown. This physician has gloves, has a cap, etc. And so you have an assistant that is helping you manage the ultrasound that is not sterile. They can hand it to you using sterile technique, but what do you do if you don't have an additional set of hands? Okay, so you got a very sick patient in front of you, and this physician has to break his sterile procedure to take control of the ultrasound and get started all over again while the patient is getting sick. So think about kind of what you would do in that circumstance. That's a very, very unfortunate position to be in. So, Dr. Trigo, without further ado, what was your solution to this problem?
Yeah, so as Dr. Salsa was saying, you're in this position a lot. Not only like someone getting nauseated, but sometimes you're doing procedures really quickly that had to be done under a complete sterile process. And you don't always have that assistant to pass through the probe. So we created just a stand that will hold the probe in a certain position so you can install this probe cover by yourself without needing any help. And as Dr. Salsa was saying, a lot of people say, that's not going to work. No one's going to use it. I'm like, I don't think so. I think people are going to use it once you have it. And that's exactly what happened. Once we had it, everyone went crazy with it. It's like, oh my God, I feel so good, like doing everything by myself. I don't need anyone there to help me anymore. I'm more efficient. I'm faster. I take care of patients better. And that's our goal, is to increase patient care. Why? Delaying care is not good for our patients. And that was something that really bothered me. If we need a procedure to be done now, why can't I just do it now? It's because I needed that assistance. So that's why we created the solo probe holder. The process was like really, really fun. I worked with a group of 5 bioengineering students to develop it. And we did R&D by ourselves in the simulation center. We tweaked this all over the place. And this actually is our last model. We have 2 versions of it. And it was a very fun process. And then we filed for our patents, which they're currently pending. It's a long process, as Dr. Salazar was saying. And then we started testing it during COVID. It's actually Dr. Salazar's idea to bring it out to the public sooner, because you can actually, after you do a public announcement of your device, you have actually 1 year to actually file for your patent, and you're actually protected. So Dr. Salazar convinced me to, hey, it's COVID times, put one in the COVID ICU, put one in the critical care in the ER. I was like, yeah, let's do it. I'm down. So I had to call the bioengineering students, hey, I need a couple of these devices, print them all out in the 3D printers and get this thing done. And we got them out. And everyone loved it. And the nurses used it a lot as well, even just as a holder. Hey, it's easier to grab from there. And they do a lot of ultrasound guided IVs, so they use the ultrasound to be able to guide their needle to put the IVs on patients that are hard sticks. And they liked this a lot. Ergonomically, the way they function, they made their process easier. No grabbing from here, no grabbing from there. Everything is in front of you. Everything is more fluid. And I think that's with everything. Whenever you're going to use your computer, you don't want to use your computer sitting in a weird position. You want to be in a nice desk. Now with the whole standing desk thing, you want to be ergonomically comfortable. which is the same goal with our probe holder. And I think that
One of the cool aspects about your probe holder here, as you can see right there in the red arrow, is that black portion of it. Essentially, it's an arm. I think that one of the coolest things about it is that you developed a way to hold it in the ultrasound machine using an existing hole. So you see in the back of it, that hole where it kind of sits, that's actually used for, it's supposed to be for the ultrasound gel. It's supposed to be a cup holder, but Dr. Trigo redesigned it, and it's actually kind of meant to be the base for it. Coco, so how did you have that idea? Just kind of random, or you saw some functionality in that cup holder? How did that come about?
Oh my Lord, this was the hardest part of our project. This took so long, months and months and months, because like first we were thinking about putting it in the rail. I said, no, it's not holding great, and I don't like it. And whenever you have a good group of people, never be afraid to push them. And I'm very pushy. I like things to look good and I like things to work. So we were looking around, we're in this machine, and can we put this? And also, you need to think about it. Not all the machines are equal. So you need to find something that every single ultrasound machine has. So your tool is universal. You don't want to be creating a different device for every company. So with the bioengineering students, I was like, oh my God, the cup holder. Make something that we can put in the cup holder. And they first developed this rubber stopper. And I was like, well, that rubber stopper works great. It's like a rubber cylinder for this one. But the others one don't have the exact same diameter. And they were like, oh my God, the phone holders for the cup holders in the cars, they are like an expandable cylinder. I was like, that's what we need. And then they created that one. And they even did one that was electric. So you will press on a button and it will open up with the motor, and it had like a very tight fit. So they went all out with it, because so like when you find an opportunity like this one, like you have the cup holder, every single machine will have one, and every single machine has multiple ones, so you can use them. And some of them will have the cup holder kind of also be the probe holder. So like we're adding a probe holder anyway. So now you solve that solution. You take a probe holder, you can put it on this one. So that was a beautiful, elegant, simple solution to that problem. And that has been one of our greatest selling points, to be honest, because it's so easy to install.
No doubts. And so right off the bat, guys, and Coco, thank you. You give me props for that one. This is your invention. My contribution to all of this was kind of thinking of ways of deploying this ASAP, and what better way during COVID, where we want as few people as we possibly can in the exam room to keep exposures down. And all of a sudden we don't have to rely on an assistant to hold the probe for us, and we can do anything we want with it. We have a place to hold it. We can put on the sterile cover on it, all without needing to break sterile procedures. So Coco, man, that's really amazing. So let's dive a little bit more into patents, and Dr. Trigo mentioned a little bit about kind of the timing of patents and what it buys you. Okay, so we're going to discuss the two types of patents, which to me is the ultimate protection when it comes to intellectual property. So usually you're going to start with a provisional patent. We're going to talk about the workflow in a nice kind of diagram, but just to kind of orient you as to what you're going to see shortly, we have provisional patents. That is kind of the original, kind of like the baby patent. It is valid for 1 year from the time that you file it. Okay. And really during that year, it allows you the opportunity to work on your intellectual property piece. You can engineer it, you can prototype it, etc. And you have 1 year of full protection. Now, what if two people kind of have the same idea at the exact same time, or they've been thinking about it, and all of a sudden both of them want to kind of create some protection around it? Well, in the United States, and it's one of the few countries in the world that do this, we have something called first to file concept. So if Coco and I had come up with the exact kind of same idea, same concept, and we want to protect it, and Dr. Trigo went to the US Patent Office and submitted his application first, that's called filing, well, he has the right to that provisional patent, and I'm left out to dry. So guys, if you ever have an idea, you want to be the first one to file. If I was really committed to creating an ultrasound probe holder like Dr. Trigo's is going to have to be remarkably different because Dr. Trigo was the first to file that provisional patent. Now, once you have your provisional patent lapses, really, and you have had a chance to really perfect your intellectual property, now you got to think about how to provide some more long-term protection for your intellectual property. And that's where a utility patent comes in, or a full patent, as people call it, is really called a utility patent. It buys you 20 years of protection. So my patent was granted in 2017, early 2018. So I am good for 20 years in which I can really do what I need to do to get my property out there on the market, make it even better, and perhaps maybe make a little bit of money out of it. Okay. We talked about infringement, and that is a nice portion about intellectual property and patents, is that if Dr. Trigo ever decides to create a tamper deterrent lock for IVs, well, Dr. Trigo might be in a little bit of hot water because I might accuse him of infringement, and that is not a fun thing to go through. Now, somebody in the chat was very, very smart, and they wanted to know, well, this is very expensive, ladies and gentlemen. The whole process can be very, very expensive, from materials to development to your CAD designs, your software that you use, to paying an engineer to help you with it, for materials, prototyping, and just the patent application alone can run you several $1,000s. When it's all said and done, if we're among friends here, my patent is going to run me somewhere in the neighborhood of about $20,000. Okay. Can I make that up later on in life as we commercialize it? Maybe. We took a chance on it, but that's very, very expensive. So if you're ever thinking about an idea, you got to get a little bit of funding, and that's one of the aspects that we're going to talk about. So you are the next Dr. Trigo, the next Eric Kolstad, maybe the next Dr. Salazar. I don't know. I'd rather be Dr. Trigo if I were you. And you have a great idea. We're going to talk about the life of a medical invention. So kind of bear with me. Let's follow this diagram a little bit. So the first thing that you're going to do is something called a needs assessment. Well, that is the exact thing. That very first slide I showed you is you have a problem. Now you think about a solution. The first question that you got to ask yourself is there really a need for this? Do I really need to spend the time and energy developing this idea? Is there really going to be an interest in it? Is there going to be a market for it? Are my patients going to benefit from it? If your needs assessment tells you that, yes, there is indeed a commercial need for this, a medical need for this, then you can proceed to step number 2. And we call that early modeling. That's when you start tinkering. I like tinkering. I like being in my garage. I like using my Dremel tools. I like using all my power tools to kind of play with things and kind of develop some of these designs and cut wood. My initial first designs of this lock were actually made of wood, believe it or not. I did a little bit of 3D printing as well, but that's when you start kind of putting your brain to work. You start doing a lot of drawings. And I even showed some of the early drawings to Dr. Fowler. I'm not sure if he remembers that going back to Old Parkland, but I did run the catheter idea by you in that little triage room a long time ago. And so that's when
I remember, Gil. I remember.
Yes, sir. And so remember keeping your group very, very tight. Well, Dr. Fowler is part of that very tight, trustworthy group.
Well, and I thought you were crazy then, and I still think you're crazy, but that's okay.
Hey, I'm a geek, and
you're a geek.
That's amazing.
That's a high compliment.
Yes, sir. Then the next thing that you guys want to do is begin to form your team. You want to have a team that's going to be dedicated, passionate about your idea, who shares your enthusiasm about it. And you're going to need to start thinking about how you're going to pay for all of this. Not everybody has $20,000 sitting around. For Dr. Kolstad, that was a lot more. Maybe at some point we can have Dr. Kolstad on with us for kind of a second part about this, but he spent nearly in the six figures. And so you start thinking about how to get investors to buy into it. Do you form a company around it? How do you go about paying for all of this? You build your team, you build your financial plan before you do anything else. The next step is prototyping. And that's when your product really starts looking like the final deal. The most common way of doing it now is 3D printing. We use fancy CAD software to give us a really good idea in 3D about what the concept is going to look like, how the product is going to function, how it's going to behave, or the software that you're using, or the lab process. You really want to begin to have a prototype. And that can also be a very expensive part of it. An engineer can charge upwards of $200 an hour to help you prototype your material. Once you have a really good idea about what your product is going to perhaps look like, that's a time to really start protecting it, guys. You can begin to protect it really at the prototype stage, but I'd like to have a really good prototype in mind, something that I've measured, something that is kind of tangible, something that makes sense for a U.S. Patent Office attorney to look at, and something they can wrap their minds around and really put that protection forward. Because now you have 1 year to do your engineering, your tinkering, delete, add, subtract. And by the time your provisional patent is lapsing and you've done a lot of this engineering, your product is going to look a lot different from your original concept. You move on to a full patent after that, guys, and that's where the hard work begins. If you thought it was hard work up to this point, this is where it gets really, really hard. Commercialization strategy. How are you going to get your product out there? This is where the doors get shut in your face. This is where you learn just how tough the world can be sometimes. And you've spent all this time and energy and money into your product, sometimes to be told, no, I don't think so. That's not for me. I like where you're coming from, Dr. Salazar. I really respect that, but we don't see a future in your device. Thank you so much, guys. And that really hurts sometimes, but you don't stop. So your commercialization strategy is going to take different forms. We're going to show you very shortly what are the different types of commercialization strategies. This is a stage 2 where you got to start deciding how you're going to test this device. For example, is it something that's going to go in the patient? Well, you're going to need the Food and Drug Administration to buy into your product and bless it before you can stick it in patients' esophagus. Okay. And so these are the very, very tough stages. Coco, tell us briefly about kind of how you went through your commercialization strategy, what kinds of things you had to do.
Yeah, so thanks to Dr. Salazar, I got into a program that is like a little school for innovators that will teach you how to strategize to commercialize your product. Most of the people in my group were mostly into pharmaceuticals, and none of them has to have like any like prototypes. So I was like, I just need to get this out. What do I need to do? Best advice I ever got is knock on people's doors without being scared or anything. I literally went into LinkedIn and I looked up all the companies I thought could be interested and started emailing all their CMOs. And you believe it or not, a lot of them answer emails and they know they've been in your spot and they want to help out and say yes to every single meeting that gets offered to you. One time I almost canceled one meeting, and actually that is the meeting that opened so many doors for me. I was in vacation. I was tired. I didn't want to do anything. I was like, why did I schedule this on vacation? But you wanted this. This is what the times you're kind of like not as enthusiastic, but you have to bring it out and do it. So it's opening all those doors. Always be open to advice. There's a very important saying that I was the first day of my accelerator program. When you ask for money, you get advice. When you ask for advice, you get money. So every time when I started my meeting, I was asking for advice. And these meetings are kind of like a snowball effect. One meeting will lead to another one and to another one and to another one. I have so many cybernetic friends now. People I've never met in my life by like in person, but we talk on the phone all the time, and these are advisors. And this is how you get your word out there on your market. Who's going to be your buyer? I thought my buyer were going to be the ultrasound companies. That's kind of like the slam dunk. Actually, they're not. And it was with one of these meetings that I know, Coco, this is not your market. Go to the people who serve the probe cards. I'm like, really? Well, I'll give it a shot. You've been on this way more than I've been. So that was actually the right door to knock in. And this is how the commercialization path goes. It is slow, but the who decide if it's gonna be steady or not is yourself. So if you keep grinding on it, it will keep going.
Absolutely. Thank you, Coco. You're going to attend a lot of meetings. You're going to attend a lot of team meetings and trying to decide how you're going to get your product out there. Once you have a good strategy to commercialize your intellectual property, then that's when the manufacturing and distribution of your product begins. That means that you found a partner that believes in your product and wants to make it worth your while to let them use and sell your device, and they can really start making it. They have the connections, they have the know-how, they have the equipment, and even more importantly, they have distribution networks for getting your product out there. So that's kind of the life of of intellectual property. And let's do our last case. This revolves around a 28-year-old gentleman who was found unresponsive at his house. The patient received CPR by EMS, but unfortunately, they've been unable to establish an IV line on the patient. They have been unable to provide the patient medications. And once the patient arrives in the hospital, several physicians, several nurses try IVs and to no avail. The patient ultimately dies, leaving the question, what do you do? What do you do when you really can't get everything? You can't get an IV line and the patient needs medications. What do you do? Well, I will show you the solution here, and Dr. Fowler knows the creator of this device very, very well. And I've had the pleasure of meeting Dr. Larry Miller in person.
Miller, our good friend, emergency physician from San Antonio.
Yes, sir.
I'm sorry,
right.
I didn't mean to interrupt, but
no.
I bet retired now, right?
No, our good friend Larry Miller, he was a guy. Larry's an interesting guy. Excuse me, he's my age, which means old, and he'd been in the ER hour after hour when he could not get an IV into people, and he said, why don't we see if we can figure out a device that will drill straight into the bone marrow? And so he invented this thing back about 15 years ago.
Yes, sir. Dr. Miller went through every step that we discussed. And Dr. Fowler was kind enough to introduce me to Dr. Miller, who very graciously agreed to host me at his home in San Antonio. And so I traveled down there. I wanted to meet him. I was a big fan of it. I wanted to know how he did it. And he shared with me two quick stories. One of them was try to figure out how to get money for the development of this device. And he told me about a meeting in New York City with a big time investor, very, very rich investor. Dr. Miller went to that investor's apartment, and it was kind of a very small area. The investor was kind of focused on his computer while Dr. Miller kind of kept talking away, trying to convince him to invest. And the investor never looked at him in the eye. But at the end of the end of the conversation, the investor goes, "Sign me up for 10 million." And that investor invested that amount of money in this Easy IO. And thanks to that investor and many others, this is what we use now. Every single emergency department in the world right now uses a device just like this to be able to access the bone marrow when IV access is not possible, or you need quicker access than that. The second story that
Gil, it was such an astonishing insight by this emergency doc, who was a very wise, very mature man. He says, we have to have a device that gives us ready access to the bone marrow cavity. And he thought it up, and he persisted in his work and ultimately got the funding necessary to do it.
And one of the big obstacles that Dr. Miller had to face is there was actually a patent for a similar concept, a similar device already existing at the US Patent Office. So Dr. Miller made the very wise decision of actually going to this inventor's house somewhere. I don't remember where that was. It wasn't in Texas for sure. He went to the inventor's house and made him an offer that this physician could not refuse. He could not decline it. Dr. Miller really bought off that patent, which allowed him to now have the freedom, the protection to pursue this. And as a result, well, Dr. Miller will has retired a very, very happy man and with a great idea. So that was a very elegant solution. So let's talk about, well, Dr. Miller is going to...
I think the number was 20 million, but you know, what do I know?
I could not even fathom what that would be like.
Is
That's
he
so
still
amazing.
the owner, or he sold it?
He sold the company.
He sold the company?
He started the company. It was a for-profit company, corporation, and I just generally know what the corporation sold for when it finally sold.
A lot. A lot. It's an insane amount. Let's talk about kind of the commercialization strategies that we talked about earlier. So Dr. Miller clearly had a commercialization strategy. Dr. Trigo clearly has a commercialization strategy, and so do I. So does Dr. Kolstad. But what are your options? So here are some basic. One of them, the first one is start up your company. You want to be able to lead a team, to hire your folks who do the work with you. You want to hire trustworthy folks, and you want to be able to call the shots. Okay. Now, one of the things about startup companies is you're doing all of the work, including selling, manufacturing, distributing your own product, and you get the benefits from it. Well, not all of us have the time to start our own company. So you might actually do what's something called an assignment. You can assign the intellectual property to somebody else. And in that scenario, I might say to Dr. Fowler, Ray, I got this awesome product with you, and I'd like to make you a deal. I will go ahead and give you the rights to my patent and everything associated with my device in exchange for a little bit of cash. If Dr. Fowler says, you know what, actually, I think I can make some money off of that, I'm going to make you an offer you can't refuse. I might say, yeah, and we strike a deal, and I'm going to assign my intellectual property to Dr. Fowler, who now owns that intellectual property. And the last aspect of it is licensing, in which this is one of the most common paths for very busy physicians like myself and Dr. Trigo. This is one of the main ways of doing it. We're going to license. Essentially, we're going to rent the intellectual property in exchange for money. So I might go to a manufacturer, or Dr. Trigo is going to go to a manufacturer of ultrasound related products, and he's going to say, I got this great idea. I got this patent. It is selling really well. So how about you guys pay me a little bit of money? We agreed on X amount, and you guys got the rights to it. You guys manufacture it, you distribute it, and you get me a cut. For every dollar that you sell, I'm going to take 20 cents on the dollars. That is licensing, and that has become one of the main ways of commercializing intellectual property for clinicians like myself. So yes, of course, there are others. There are more kind of intricate ways of doing things, but kind of far and wide, these are the main forms of doing it. Coco, if you had to, can you share with the group what your commercialization strategy might look like?
Yeah, so as Dr. Salsa was saying, so in the licensing, there's two ways of doing it. You can either completely do like a licensing transfer kind of deal, which is you will sell your patent rights for an X amount of money. So it's kind of like a transfer in the assignment part. Sometimes you can do a kind of like a hybrid, which is more common. So you're going to rent your license, but you ask for a chunk amount of cash upfront to cover most of the expenses you have already paid for. So that's kind of the path I am leaning more towards. Something that is very important, you don't only need to cover for the amount of money you have invested. Remember, your time is also very, very valuable. So time is money as well. If you have invested over 200 hours of your time in a device or in a project, you also need to get that time back. That was time you were not working, you were not getting paid. So you need to think and calculate that amount of time so that you can also calculate that into what your device is worth as well. So when you go to an investor, say, hey, I'm trying to license this for this percentage for royalties, and this is the amount of cash I'm asking upfront. Like, why? You need to have an explanation for all that stuff. So that's kind of like my strategy at the moment with my licensing agreements.
I think very few of us are actually going to kind of do what Dr. Kolstad says he or does. He is really a part-time physician, but his full-time job is running Attune Medical, that company. I am not nearly as smart as Dr. Kolstad, and my commercialization strategy is going to be strictly licensing. So more on that, folks. We're almost there. I wanted to share with you kind of one last slide, and everybody wants a piece of the pie. When you have a great idea, everybody wants a slice of it. Everybody wants to reap the benefits. There you get into some kind of very interesting circumstances when you work for an academic institution like myself, like Dr. Fowler, like Dr. Trigo, like Dr. Kolstad. And really what you got to remember when you have an existing relationship with an academic center, academic clinicians need to have some very special arrangements. So this is very interesting. And yes, that piece of pie does look like a bomb. Yeah, that's my favorite. If you ever want to make me a cherry pie, I will pay you. I love cherry pie. Anything that you create as member of an academic center, paid by an academic center, and if that piece of intellectual property has something to do with your job, that piece of intellectual property contractually belongs not to me, that belongs to the University of Texas Southwestern Medical Center. That's a contractual obligation. When I sign my contract with them, and I do every year, I agree to it. And that is very carefully monitored. Every organization like ours has really an office, like the Office of Technology Development, for example, at our organization, monitors these agreements very, very carefully. And so what if, Dr. Salazar, what if you create a brand spanking new lawnmower? And it's the greatest lawnmower of all time. Does that belong to the University of Texas Southwestern? No, because that lawnmower is not part of my job at the University of Texas Southwestern. Maybe someday they'll kick me out of clinical practice and I'll go mow the lawns for them. I will gladly do so. But for the time being, if I create a lawnmower, that belongs to me. Anything medical related to my job belongs to the University of Texas Southwestern. So what do we do in that circumstance? Well, you created it. It's your idea. You saw a problem. You did a needs assessment. You went through that entire algorithm, that entire pathway, all the blood, sweat, and tears that we discussed. Well, thankfully for us, there are arrangements that can be made. And really, essentially, it becomes sharing of the profits, the benefits, the royalties from the sale, manufacturing, and distribution of that intellectual property. Okay. So, different academic centers have different breakdowns, but a percentage of monies made are going to go to the inventor, like myself. Part of it are going to go to the University of Texas Southwestern. That's going to go to all the way to the president's office and be able to fund all the wonderful things that they do. And a good portion of that is also going to go to the inventor's departments. In my case, the Department of Emergency Medicine, or if you work in a laboratory, it's going to go to your laboratory. And so kind of the percentages kind of vary by institution, but just to give you an idea, ours, if we come up with something, 50% is going to belong to me, 25% goes to UT Southwestern, 25% is going to go to the Department of Emergency Medicine or the laboratory that I work with. And that's a very generous agreement that we had. Yep. So ladies and gentlemen, that is a big overview of how clinicians like myself, Dr. Trigo, Dr. Kolstad, Dr. Miller come up with ideas. and the process we go through as physicians in getting these ideas to market, making them a reality. And what I want to get out of it for you is that if a young kid from Guatemala, from a tough neighborhood here in Dallas, can do it and become an inventor, so can you. Trust me when I tell you. So thank you so much for having me tonight. I really appreciate you all being here tonight, and I'll open it for any questions.
Gil, this is Ray. I at this advanced stage of my life, I have to say that the most important thing for me as a person, as a clinician, as a doctor, is to work with people that I just love working with. And you're one of those people, Gil.
Thank you, Ray.
You're a great doctor.
Thank you, sir.
And even Coco Trigo, even though he deserted us and left us, he's a great doctor. So
what a privilege.
Thank you, Fowler.
What a privilege to be among giants in emergency medicine. So thank you so much, Ray. I love you, and thanks again for having me.
I think one thing that is very important, guys, is always believe in yourself. A lot of people have great ideas. You'll be surprised. Almost no one, or a very small percentage, actually pursue ideas to actual something that is touchable. So if you have an idea, never be afraid to go for it. Never be afraid to make mistakes. Mistakes are actually better than successes. You're going to learn way more from all the mistakes you're going to do on the path than actually from all the things that go right. And it is nothing wrong with not knowing what to do. Just go for it.
So Coco and Gil, it really strikes me that it's not artificial intelligence, it's really assisted intelligence is coming in a tidal wave. It's going to be with us. It's going to help us on decision making and differential diagnosis creating and so forth. So do you have thoughts specifically about the future of assisted intelligence?
There is always going to be a need for clinicians to develop the algorithms and putting the human touch in all of these processes related to artificial intelligence. And there will be commercialization opportunities for these algorithms. There will be companies who will really very gladly employ physicians like ourselves, clinicians like ourselves, to develop these algorithms for artificial intelligence uses and perfect them. There will also be ample opportunities to legally protect these algorithms, these concepts. And as long as there are human patients, there is always going to be a need for human clinicians delineating these algorithms, which can be protected. But what a phenomenal tidal wave that is coming to actually deliver even better care using modern technology, as long as humans are actively involved in the development and oversight.
I think EKGs and EEGs for seizures are going to be all read by really high quality computers in the very, very near future. I think those are the two things that are going to definitely be the first ones to come out. I think with radiology, it's going to take longer. There's a lot of subjectivity there. I think EKGs and EEGs will be ones that's going to be right there around the corner.
It's amazing.
What I think is going to happen, though, pretty soon is that we're going to have, I don't know, diagnostic decision-making software built into Epic, our electronic medical record, or whichever electronic.
No doubt.
That then, as we collect data on our patients, does an accelerated decision-making process for us. We already have stuff for sepsis, lactate is up and so forth. But I think, Gil and Coco, that we're going to see this accelerated decision-making process. What do you think?
Go ahead.
100% agree that clinical decision processes are going to be the main ones. Now, I want to put a kind of a cool thought in your mind. Some of the things that we struggle with that keep us from being efficient. For example, one way, for example, that I've explored is language barriers. What if there's not an interpreter who can proficiently help us with a patient who speaks a dialect of Spanish, for example, and there is no one available? Can there be artificial intelligence algorithms that are going to help us with these algorithms? So definitely clinical decision-making tools. I'm also going to be looking for things that increase our efficiency, patient satisfaction, and safety in the delivery of care.
Well, Gil, the other day I had a woman come in with her 7-day-old child, and she spoke only Mandarin. And the only way we could communicate is that we used Google Translator. And so, is that the way of the future? Are the translators going to be built into our medical record, do you think, Gil and Coco?
Coco, what do you think?
So I think that's going to happen. And I think there's a lot of new technology with telemedicine is going to be integrated. It's already happening. That's already exists. I think it's not mainstream yet, but I think telemedicine, scribes, and interpreters are all going to be integrated within a EMR. I think scribes, I saw something about using Google Glasses and having like a scribe at their house with just watching everything that you're doing and listening to everything. Very high definition camera, very high definition audio. And I think that is great, especially during COVID. Well, I don't want to have a scribe going into every room or close to rooms. They can be at their house and they can listen to everything that I'm saying. They can see everything that I'm seeing. And we can even share a screen. And I think that's going to be the future for sure. When that's going to happen, I think it's going to happen sooner than we think. Especially COVID is accelerating all of these processes even more, especially telemedicine.
All right. So Coco and Gil, the session tonight has been about innovation in medicine. Do you think that there will be an accelerating nature of innovative ideas, or are we at the end of innovation? What do you think?
Sir, this generation of our friends who are on tonight watching us and who represent the next generation of you and me, it is my humble opinion they're going to see an accelerated and very exponential growth in technology available to them to take outstanding care of patients in every facets, all the inefficiencies and the things that keep us from delivering world-class care. The next generation is going to see an exponential growth in software applications, artificial intelligence for sure, and much improved methods of creating decision-making tools for patients, essentially allowing clinicians to do what they do best, just bring humanism and dignity to patients' lives while allowing technology to do a lot of the heavy lifting and some of the things that keep us from being at the bedside taking care of patients. So enjoy, folks.
Gil, being in a medical school, being around one of the most competitive residencies, what is it? We have 1,700 applicants for 22 spots for our residency. So a very competitive program. It seems very apparent to me that the amount of information available to us is never enough, that we have to study and reference and look things up all the time. Do you see any change? Is that going to get any better? Or is that going to continue to be the case?
Go for it, Coco. What do you think?
That's going to continue forever. And I think it's going to be more and more and more and more every single day. I think this generation likes to think outside the box. They like to see what else is out there, and they want to really extend that to the limit. And they are going to really increase the amount of information that's going to be out there. And they're trying to get this information even more readily available every single day. I think You think about it, 10, 15 years ago, there's a lot of like PubMed stuff. You needed to pay for it. You needed to be in a library like your school pay for some stuff like that. Now a lot of all that information is free. With podcasts, that has expanded greatly. That has been even more access to information. I think it's going to be even more and more.
Agree.
So Coco, wait a minute. So you went through our wonderful EM residency program. You studied all the time, you read all the time, and now you've done a couple of fellowships. Don't you know everything that you need to know? Or are you telling me that you're going to have to be on a program of continued study in the future?
I think you have to be continued studying. I think that's especially being a doctor. If you're not studying every week, you're going to be outdated. You need to be, because there's new studies, new articles being written every single day, and things are changing faster than ever just because of the access. I think the access, the reach to be able to access all this information so easily and so fast is making the turnaround of information be exponential. I think.
Yeah, I was picking on you.
I know you are.
I've come to the decision that if I don't know something, there's one of three reasons that I don't know it. It's either I've forgotten it, which with my old demented state, it could be, or it's the fact I never knew it and just medicine is so complicated, or it is a new fact that I don't know. And the thing is, it's all three. All three things will always relate to how we don't know stuff in our work. Gil, go ahead, take it.
All right, so for our Q&A session, to start it off, is there a specific place where physicians have to file their patent application, or does everyone kind of go through the same process, whether they be an engineer, a scientist, or a physician?
The amount of work that goes into filing is pretty extensive. You're always going to need an attorney, a intellectual property attorney that can help you with the filing, with the detailing, with the when the U.S. Patent Office kicks something back to you. That process necessitates somebody who knows what they're doing. There are attorneys who do that for a living, and that is the same for clinicians like ourselves, an engineer with an idea, or Mr. Smith down the street who has an idea on how to improve a lawnmower. It's pretty much the same pathway. Can you do it all on your own? You could, but it's hard without an attorney who knows what they're doing. So you're going to need a little bit of help for that, and you're going to need to pay them.
You want to know who did it on their own? That is a crazy story. The inventor of Spanx. She had no money, so she actually taught herself how to write a patent, and she wrote it all down, and she had someone to just look over it. And I heard her story. That for me, I was fascinated because I read over my patent, and it took me hours. And I was like, I couldn't write this even if I tried. I'm like, how did this lady did it? It's incredible. So hire a lawyer to do it for you. It is way more efficient. And I think that was, if not, I would have never been able to file a patent if I didn't have an attorney to do it with me and meet with them. That was crucial for me as well.
What ends up happening after the 20 years is up for your long-term patent? You have to refile, or?
It's open. Hey, my friend, like hopefully by 20 years, your commercialization strategy would have paid off. A classic example is the drug sildenafil, better known as Viagra. It's a pharmaceutical. That's a type of intellectual property, and the protection lapsed after the 20 years. And there's some nuances to it, but that's basically what happens. So what happens after that protection time ends? Well, now it's free for all. So now there are multiple makers of the drug sildenafil. Really, a lot of pharmaceutical companies can make it because the original company no longer has the rights to it. So most of the time you will have moved on with your life. And so either your technology has been replaced by something completely different, or the inventor loses interest, or they pass away, or they retire, on and on and on. But really, the life of a patent is really about 20 years all together. And to my knowledge, there's got to be some examples in which people refile. There's just probably not that many out there.
Okay, that's interesting. I'll go over like one last question. What are some of the complications that either you or another intellectual property developer in medicine approach when contacting manufacturing companies to produce their product and make their idea a reality? How hard and costly can a product be to produce, especially at high volumes?
I'll go first and share my experience, and I'd love to hear Coco's conversations. Manufacturers, they're kind of like you. They want to make some money off of it. They may like you as a person, but if they're going to invest in you and they're going to give you an opportunity to manufacture your materials and help you sell it, distribute it, it's not because they think you're a nice dude. They really want to make money off of it. And there's a couple of factors that go into their decision to play with you or no. One of the main things is that manufacturer capable of manufacturing and distributing what your idea is. For example, one of the roadblocks I faced was the fact that this IV catheter, that's a really small piece. There are not a lot of manufacturers in the world that can do something that small, that intricate, with moving parts. And the smaller it is and the more moving parts, quite literally, the more expensive it is. So they think it was a great idea. Yeah. They think they could make some money off of that. Yeah. But their capabilities have to be there. That was the number one roadblock for me. And then number two was the fact that a lot of folks thought that there were simpler ways of doing it, or they don't see this type of cases and they don't see the purpose of it. And so you kind of feel hurt. It's like, well, I did and it sucked. Why don't you want to apply? It's like, well, it doesn't really affect kind of the day-to-day life for a lot of people. So I don't want to do it. Coco, what are some roadblocks you run into?
Yeah, I think a very important thing to distinguish manufacturing and distribution. Distribution is as important as manufacturing. So you want to think about this backwards. Imagine that you are the CEO of a hospital, right? You have a lot of things going on. Let's say someone brings you a new device to bring into your hospital. You don't want to use a separate buyer than the buyer that already supplies maybe 100 of the products you already have in your hospital. Why have to go all the way around and just make one single order for this person when I make single order for this other one and supplies me like 100 products? So distribution is very important. You want to have a chain of distribution that links to your manufacturer. So other than convincing a big factory to build your device, build it cheap, build it fast, and be easy to be shipped around the world, who is going to get it to the hospital? If you can get those two linked, you are golden. So that was kind of like my strategy when I was reaching out to manufacturers. I wanted someone who was building their own devices, their own kind of products. Or if they are outsourcing it, they already have that link done. So for example, one of the companies that I'm actually talking with, they do a lot of their devices in-house. They have like their own little factory. And their distribution channel is perfect because they distribute many products to different hospitals, not only one. So in my case, I worked around convincing one client or one interest party to get my product into their company so they can do both my manufacturing and my distribution. But that was I got very lucky. Usually you have to figure out both on your own. Sometimes once you figure your manufacturing, that manufacturer has a lot of links with your distribution. But if they don't, you need to find a new one or build it yourself. And that is very, very difficult because you can very easily be stuck with 1,000 of your product and nowhere to go. So you cannot be like just knocking on a door. Hey, I have this device. Can you just buy it from me? A big hospital will not do it just because it's too much trouble for them to get it in. they want you to use their distribution channels that already exist. So those are two important things to always keep in mind when you're talking about getting your product to the market.
One last item, if I might mention, you may think you have a really good idea. You may have manufacturing and distribution channels. A lot of times folks won't want to play with you and pay for it unless you have a clear record of sales and you've already been selling it. So if you have, best of luck trying to get a contract or license a product that hasn't sold anything. Your product better be very good or somebody better believe in you. Because if you don't have a sales record, your life is going to be very hard. But everybody is going to face that at some point, and you got to be persistent. So eventually, somebody's going to believe in you.
Also, just to piggyback exactly on what you just said, Dr. Salazar, sometimes you can have a device that's going to help them sell more of their own products, and that's another way to look at it. And it is a little bit harder to find that perfect balance. For example, in my case, the way I try to market is like, hey, like you're not gonna buy 100 of my device for a hospital every year. You're gonna buy maybe 10, 15, or 20 of them. But what if I link it to when you're selling your probe covers? Because they're gonna buy thousands of those. So it's like, hey, if people love my device, if it is the same brand as your probe cover, they're going to buy more of your probe cover because we're using the same distribution, same manufacturer. So having my device will help you sell more. It's like, well, they actually really like that. And that was one of the ways that I was able to push for mine. And again, I got lucky because everything happened at the exact same place. Sometimes that does not happen. You have to kind of link all these people together. But it's all the act of convincing and the act of keep knocking on doors until you get all those people in the same room.
Well, I would like to take this moment to say thank you so much, Gil and Coco, for what a very innovative session to talk about how you think about new ideas, how you make those ideas happen, how you protect them, how you ultimately can end up perhaps making money off those ideas. What a great session for all of us. This is terrific, and we really, really appreciate this. The 200 folks that were here tonight, Coco and Gil, that were listening to your wonderful talk, we really appreciate it. So, Aditya, what is the plan now for folks that are going to take the exam? Can you clear that up?
Dr. Salazar, if you could go on to the next slide. So here is the session 64 quiz. If you scan this QR code with your phone, it'll take you directly to that link. Please be sure to download your certificate once you've passed with the score of 70 or above. And the quiz will be closed on 8/17 at 6:59 p.m.
Thank you for having me.
Yeah, I do want to ask everyone that is out there, please put thank you, Dr. Salazar, thank you, Dr. Trigo, into the chat so they can see how much it meant to you tonight to see this. Please put that in there, please.
Thank you, guys. It's a pleasure.
Look at that. That's wonderful.
Thank you all.
All right. Aditya, what else?
That should be all. Thank you, Dr. Salazar. Thank you, Dr. Trigo, for sharing this side of medicine that I'm sure many of us did not know much about.
Thank you all for having me,
guys. We appreciate it.
I want to thank you, Gil and Coco, for coming tonight. It means a great deal to us. This is, what is it, the fourth lecture? Is that right, Aditya?
Yes, that is correct.
What an amazing time we've had on the web, appealing to students all around the world, and over 1,000 universities worldwide. We appreciate so much that y'all continue to come back. And if you keep coming, we'll be here. So we're going to keep coming back. And I want to thank everyone for their tenacious assistance on making this thing happen. So Aditya, do you want to, I guess we're done for the evening. And so I want to thank everybody.
Before signing out,
I wish you a good evening.
Dr. Fowler, before signing out, could we go over Dr. Salazar's Instagram information for the giveaway? I see a few.
Please go right ahead. Please go ahead.
Dr. Salazar, could you go back to the first slide with your Instagram, please?
Yep, I just put it in the chat as well. And then the website for us, www.vcop.ws. Check us out. We have 6 episodes we recorded a while back, hour and a half with cases, clinicians from different specialties. And those are available on our learning management system. We charge a small fee to cover the cost of the learning management system and to give scholarships. Do give us a look, and we hope to see you soon.
All right, everybody. So thank you, everyone, for a great evening. Gil, wonderful. Coco, wonderful. Aditya, thank you so much for managing this. And we wish you all a good evening and a good night. Thank you.